This is Namitha Sethmota for NEJM Catalyst. Today, I'm speaking with Dr. Tejal Gandhi, Chief Safety and Transformation Officer at Press Ganey, where she is responsible for developing and leading innovative patient and workforce safety strategies, best practices, and technology. Now, Tejal, I have known you from your days leading quality and safety at Mass General Brigham and then during your time at NPSF and IHI. You are one of the key leaders in the quality and safety space. You defined the cutting edge research over the last 2 decades and have had operational roles in which you led organizations to improve their quality and safety outcomes. Some of my favorite recent talks of yours have been so insightful and innovative. Your comments about safety and AI, about ambulatory safety, and expanding the definition of harm to include both emotional and financial harm. I am thrilled to have you here today so that we can take advantage of both your academic and operational expertise. It really is a rare combination. And to have you talk about a concept that has been around for a long time, the high reliability organization. And as with all concepts that have been around for a while, we need a refresh given today's healthcare landscape. We are going to discuss if and how the HRO concept is still actually even relevant, and more importantly, what our listeners can and should apply to their own organizations to realize improved outcomes. Tejal, thank you for speaking with NEJM Catalyst today.
Thanks so much for having me.
Let's level set for a minute. I have heard this term, high reliability organization, used in multiple different ways over the years in multiple different settings. What is a reliable, no pun intended, working definition that we should use for the conversation today?
Great question, because I do think that there are different versions of what HRO, I'll use the acronym, really is. And one of the things that I talk about when I talk about high reliability organizations is actually we should use the term HRO to mean high reliability organizing, because it's really a verb. It's this very active state that you want your organization to be in. And the definition at a very high level is performing as intended consistently over time. That's what we think about with high reliability. Now, underneath that, obviously, there are many frameworks out there, and the one that has most commonly probably been talked about is from Wyke and Sutcliffe with 5 key principles. High level, performing as intended consistently over time, I think is a really nice way to think about it. And it means high reliability in HRO is not just a safety thing, even though it came from safety. It's really a chassis to improve or do your work in any facet of industry, right? Like you could be working on quality and safety, you could be working on finance, you could be working in a supermarket, you could be working in healthcare, but that goal is performing as intended consistently over time. And then the 5 key principles that I'll just quickly walk through are preoccupation with failure, reluctance to simplify, sensitivity to operations, commitment to resilience, and deference to expertise. And that comes from Managing the Unexpected by Wyke and Sutcliffe, but there are other frameworks as well. And I think that's the one that's most commonly used as kind of what are the principles underneath HRO.
All of these make sense when we're thinking about applying to quality and safety efforts. And you mentioned earlier that it could be applied to a lot of different arenas. What specifically within care delivery that's not quality and safety can we think about applying these principles to? And related to that, what role does innovation play as we think about applying consistently over time?
Yeah, so well, quality and safety is so broad. I'm trying to think of an example, not quality and safety, because I, of course, think everything's quality and safety. Even if you think about finance, right, or billing, and where are the failures occurring in billing? How do we understand, how to improve our processes? How do we understand how to mitigate some of the impacts of errors in finance? Do you have a culture in your finance group where if people have a concern, they can raise it? Those kinds of concepts, I mean, that we talk about them in quality and safety, but they can certainly be applicable in a non-clinical arena as well. You still need to have a culture where people are going to speak up, be able to provide their expertise, even if, from the sharp end, et cetera, to improve processes in something like finance that we don't think of as clinical at all.
Yeah. And you're getting at something really important here, which is that ultimately so much of this is about culture change across the entire organization and comes back to your opening comment around how HRO is a verb in the sense that you are continually in an active state of organizing of and building culture is a key component of that.
Exactly. And, you talked about innovation as well. I do think that there has been this misunderstanding that high reliability means standardization. And standardization is a tool and it is a useful tool, but that is not what high reliability means in that it is, all of the things I just described, where you have to constantly be understanding what's going on in your organization and making changes and improving, et cetera. So, standardization may solve some things, but it's not going to solve everything. And innovation is critical because even as we think about applying HRO principles to modern healthcare today, and think about all the best practices of, how do we create psychological safety? How do we do our tiered huddles and our rounding? How do we empower our people? There are going to be ways to constantly innovate how to do that better. And, that could
Mhm.
include using technology, right? So we want to use technology so we can have our huddles be more efficient and those kinds of things. But it may be non-technology solutions. There may be new and innovative ways to build psychological safety as more research comes out on psychological safety. And so innovation is critical to how we continue to do the work on HRO. I mean, 20 years ago, 25 years ago, when we started really working in safety, we brought the human factors lens to our safety work. And, it really hadn't been, and usability and all those things, and it hadn't really been that embedded into healthcare. And we did a lot of innovative process redesign work around human factors and usability, over the last 25 years, which, is part of this HRO process. And we need to bring those techniques into healthcare. Um, One other thing I would mention is when you think about HRO, high reliability organizing, I like to think about it as people plus process plus technology. It's looking at all of those areas. And you talked about culture as being critical, which is part of the people part. And I'll come back to that. And then process redesign, the human factors, usability, all of that. And then technology is a piece of it as well. And how do humans effectively use the technology? All of this is part of HRO. And when we think about the people part specifically, there I think has been some uh, evolution there as well. Because again, 25 years ago, we said, oh, it's not people, it's systems. So we did
Mm.
the culture work, but we said it's not people, it's systems. And then we did all this, human factors, usability, process redesign stuff. But what we've really learned is it is systems and people are working in those systems. We can't ignore the people. We certainly don't want to blame and punish the people, but there are ways to make our people more effective parts of the system and even more effective barriers to harm occurring in the system. And that's what a lot of the HRO principles help to build as well, these sort of skills that you can build in your people so they can be more effective in the system and be able to, again, provide their expertise, be able to react to the complex situations we have in healthcare, have better, stronger teams. All of that is to build stronger people, as well as working on that process and technology piece.
And you work a lot in health systems. And so I'm going to ask of any of these, whether we're talking about the people skills that you're just talking about, the process, the tech, what are some examples of success? And just as importantly, why were these specific organizations successful?
So we've worked with a lot of health systems around embedding HRO principles and practices, and we've seen some really remarkable results with large reductions in serious safety events with implementation of these people skills as well as the process pieces. And now we're adding in technology as well. And, some of this has been published in New England Journal Catalyst, actually, with that shows the impacts of this kind of work on those serious safety event rates. And pretty universally, in terms of success factors, leadership commitment is critical. And it sounds kind of trite. We always say, oh, you have to have the leaders, but it really is absolutely critical that from the board and C-suite on down, that there is a commitment to this work, because it has to, we talked about leading culture, and that's where culture gets led from. And it is that C-suite leadership, but I also talk about leadership at all levels, because it can't just be the C-suite. You have to really embed this into your middle managers, your physicians, who are, all leaders in some way. But that leadership commitment and support is critical. The frontline engagement is critical, and really making sure your frontline understands why this work is important, what the purpose is, what they need to do, what are the practical, tactical things that they need to do. Other key factors, I would say, is thinking about sustainability from the get-go, because what we've seen a lot is organizations do this work and start, and then things kind of fall apart over time. And so really having continued reinforcement and sustainability built in from the beginning, because one of the big failure modes that we've seen is it's going great and a leader leaves and then things fall apart. So it can't be that it's reliant on that single strong leader. You have to have that sustainment piece built in, so that even if your CEO leaves, even if your chief quality officer leaves, it is going to remain. And the way I like to think about describing that is it becomes habit. All of these principles and practices become habit. And you can't imagine a time when you weren't doing it. And the great example I use is the surgical timeout, which,
Mm.
you and I worked together back in the day. And I remember it was many years, 5 years probably, of hard work to implement the surgical timeout in our academic medical center. And it wasn't unusual. Every organization was struggling with it, and there were all these barriers and so forth, and it was really hard and painful. And now we are at a time that, and the surgical chief was critical to advancing it and all that stuff. Now we're at a time where people can't imagine a time when we weren't doing timeouts, right? So we have to get that same way with the huddles and the leader rounding, and having the skills to have psychological safety in your organization, and to be able to question and escalate concerns, and all of those kinds of things that we teach have to be like, you can't imagine a time when that wasn't how you did things in your organization.
Mhm. That is a really helpful North Star. I'm going to refer to two things you said earlier in the conversation, because I think our readers will find it compelling to discuss. One is thinking about the current market around workforce and the challenges related to burnout, to shortages, to people worrying about how they're going to have to do their job differently, if at all, because of AI. Connect for us how the concepts of reliability and strengthening the people and workforce and process in our complex systems of today. How do we reconcile those two?
I think there's a really tight connection with your strategy around your workforce and doing high reliability organizing. If you build a culture of safety, psychological safety, strong teams, we have data that shows that strong safety culture, which includes components of all of that, is strongly correlated with increased workforce engagement and decreased turnover. And so, this should be part of your engagement strategy and your retention strategy, because people want to work in organizations where they think they are delivering high quality, safe care. They want to work in organizations where they're working with strong leaders and strong teams, where they feel like they have a voice and they can speak up or raise concerns. Like, all of that is a way to engage and retain your employees. So I actually think, you know, it's a critical aspect of your strategy as you go forward. And it's not only about that people piece and the culture piece, but definitely if you're working to make your processes more reliable, to understand where things may be failing in a very real-time way with that rounding and huddles, and then taking the actions to improve those things, that too is going to be a way to engage and retain your workforce because they feel like they're being listened to and problems are being solved.
The second point, and I should have said this much earlier, is around making sure we're broadening the aperture enough to think about what else is out there in terms of frameworks as we think about improving, in this case, quality and safety at our organizations. Are there other frameworks that are out there? What's the quote unquote competitor framework to HROs? Are there any other alternatives, and how should we be thinking about those?
Well, there's certainly been other articles about HRO that maybe highlight a little bit of of different principles or practices, but they're all, I think very overlapping and aligned. Some of the frameworks that sometimes have been considered competitors, but I don't think are competitors, is the process improvement frameworks, things like, Lean or Six Sigma, et cetera. And I really think these are complementary because it's really a false choice. Like, of course, you want to do your high reliability organizing and all of the things I've already talked about. And when you identify problems or issues with processes, et cetera, then you have to use robust process improvement to actually improve the thing. And so you have to think about, again, human factors. You have to think about lean. I mean, there are all these principles that can be used to drive the improvement. So I feel that these things are, again, very complementary and intertwined as opposed to competing with each other. And too often, I think a new framework might come along that people think of as like the shiny new object, whereas I think, you can't get away from having to do the hard foundational work of culture and this high reliability organizing. And then you interweave in some of these other tools that can be used to, do some of the improvements that need to occur.
I appreciate that framing. Uh, we have time for one last question, and I always end the same way because we here at NEJM Catalyst are optimists. What are you most optimistic about, Dr. Gandhi, in terms of advancing safety and quality in the next, say, 2 to 5 years, and why?
So I am definitely someone who has always felt like technology can improve quality and safety. And that was what I started doing research on over 25 years ago. And finally, the technology maybe has caught up to the opportunity. Um, and so I do think from a quality and safety standpoint, some of the challenges that we've had for the last 25 years, we are going to be much more able to solve as we go forward, especially with the advent of AI. And I totally understand. I'm on the AI bandwagon, but I understand we have to be careful. There's unintended consequences. There's all these things we have to be mindful of. But this idea of, can we get much more upstream, predictive, and proactive in our quality and safety work so we can actually intervene before harm happens or intervene before somebody doesn't get the treatment that they were supposed to get or whatever it might be? I think that AI is going to really help us there. And, a colleague of mine used to say, right now we measure the people who fall through the ice,
Mm.
and we need to be measuring the thickness of the ice. And I think AI is going to help with that, with getting much more into this predictive world. And as well, AI is going to help the work of quality and safety. So what I mean by that is right now we often are overwhelmed in safety, particularly. We get thousands of safety events reported into our event reporting systems. And then people have to manage these thousands of events, and it can be very onerous and a one by each type of thing. And we often don't really see the themes and trends and common causes and all those things because it's a very manual process. And AI is going to be very good at taking those large amounts of data and helping us do the analysis so that we can get to insight and get to action far more quickly. So those are the things that I'm excited about that I think will really advance our work. And to your point, in the next couple of years, I mean, it's really gonna happen quickly.
And we are glad that you're going to be at the helm, steering that work. Tejal, thank you so much for joining us today.
It's my pleasure. Thanks so much for having me.